good energy in the room. That's always a good sign. So thanks again for being here. I appreciate your time, making time for this session. We'll get started with a reflection, then our usual housekeeping, and then I'll hand it over to Dr. Strittmatter for the main event. This reflection is called If I Could See the World Through the Eyes of a Child. If I could see the world through the eyes of a child, what a wonderful world this would be. There'd be no trouble and no strife, just a big happy life with a bluebird in every tree. I could see right, no wrong. I could see good, no bad. I could see all the things in life that I've never had. If I could see the world through the eyes of a child, what a wonderful world this would be. If I could see the world through the eyes of a child, smiling faces would greet me all the while. Like a lovely work of art, it would warm my weary heart just to see through the eyes of a child. I could see right, no wrong. I could see good, no bad. I could see all the good things in life I've never had. If I could see the world through the eyes of a child, what a wonderful world this would be. All right, so a few things on your tables that you're used to seeing. We have our session, No Go Friday session for next month, which is on pharmacy services. So mark your calendars, please, for Friday, February 12th. Information about Dr. Strittmatter, you have what we call a buck slip with some information on his location and his services. And we have our comment card, which I talk to you about every month, so please fill that out. And if you're making a suggestion about a future topic, please include, if you would be so inclined, to include your name or phone number, a way that I can reach you to find out a little bit more about what it is specifically you're looking for. Very often we'll get topics like behavioral health. Well, guess what? That's extremely broad, and so my chances of actually hitting what you're asking for are pretty slim unless I'm able to talk with you. So please include that additional interest or information. And then of course we've got some prize here. If you're interested in a chance to win that, fill out the green slip. It looks like we have some veggie bucks and a water bottle infuser. Okay. And now I'll go ahead and introduce Dr. Strittmatter to you. He is one of our ophthalmologists with the Fond du Lac Regional Clinic. He practices over at our Health Plaza A building. And he received his medical degree from the Philadelphia College of Osteopathic Medicine and his residency training in ophthalmology from Ohio University Doctors Hospital. I'll leave all the rest of the detail about what he specializes in to his presentation. So please join me in welcoming Dr. Strittmatter.
Everyone hear me? Hit the button, but I don't think it went on. Do I have to hold it in?
Yeah.
Oh, there we go. Good morning. Can everyone hear me?
Yes.
All right. First off, I want to thank everyone involved for setting up today and getting this prepared, especially Katie for keeping me on track as far as getting this presentation ready and just inviting me to be here. It's a great honor to me, and I'm just happy to be here, and hopefully you find this somewhat interesting. So I'm going to talk about common eye concerns. Pretty much everything I talk to you about today constitutes roughly 80% of all the patients and their complaints that I see on a daily basis. So quite a majority of what I experience and what a lot of you may, through your life, experience from an eye standpoint. So she gave me a little presentation as far as who I am. I grew up outside of Pittsburgh, Pennsylvania. I am a Steelers fan, but I tend to cheer for whoever's in the area, so go Packers this weekend. Went to college out in Philadelphia as well as medical school. It's nice to visit out there, but not a place to live, trust me. And then I was in Columbus for 4 years and met my wife down there, who's from Janesville, Wisconsin, and so we are up here. So I'm an ophthalmologist, and one of the common questions I get is, what's the difference between you and an optometrist? And the big thing is an ophthalmologist is an MD or a DO, which is a doctor of medicine. We have not only our 4 years of medical school, but we also have a year of internship and then at least 3 years of residency. If you decide to do a fellowship and specialize in a certain part of the eye, then that can be an extra 1 to 2 years. An optometrist is called a doctor of optometry, and they do essentially the same things. They only have 4 years of optometry school after college, and so they diagnose and treat a lot of your eye issues. They can do regular diabetic screenings, but if anything becomes surgical, then they send it to us since we have the surgical training after medical school. They're And why I really appreciate them is they do a lot of the contact lens fittings, and they're just the masters of refraction. So if you want, the best possible glasses, or there's certain intricacies of your prescription, I might refer you over to them because that is really their bread and butter. Whereas if you need cataract surgery or plastic surgery or some type of surgical intervention, they're going to be referring over to me. So we really complement each other very well. And in our office, we have 4 optometrists and 2 ophthalmologists. So anything you need is essentially covered. I put this in here just because I'm asking all of you to kind of help me with any patients you may encounter that if they mention that they have an eye appointment coming up, take the time to just remind them we are no longer here at the hospital. We still, despite sending out call messages, have people calling us from here at the hospital saying, where are you guys? We can't find you. So we are now up at the Agnesian Health Plaza, right beside the surgery center over on 151. It's a really beautiful office. They did a fantastic job with it. I did get to see where we were located before, and just a lot more room. And it's a good exercise for the patients when they get there because it's quite a long hallway to get around. So these are going to be our main topics today. Common eye concerns. We're going to cover cataracts, glaucoma, macular degeneration, vitreous floaters, and dry eye. So cataracts. It's the most common cause of reversible blindness in the world. In just the United States alone, it affects about 20.5 million people. And cataracts can be subtle, where you may not be able to see them with the naked eye, and they can be as severe as if you saw this patient and just looked in their eyes, you'd see that white cloud. So where is a cataract? That's usually one of the questions I get. Patients think it's something I can flick off the front of their eye, or they think that it's something where I have to actually take the eye out of their head to get to it. A lot of my time is just educating them of the physiology and the anatomy. And so the cataract is right behind the colored part of your eye, or the iris. And so the pupil, which you see gets bigger and smaller depending on the light, we dilate that, and that's essentially a direct access to the cataract itself. And so that's basically how cataract surgery is performed, is we make small incisions in the very clear window and use very small devices to get access to it. So what are the causes of cataract? The nicest way possible I have to tell people is birthdays. That is by far the most common cause. There are some things that can cause people to get cataracts at an earlier age. Prior history of trauma to the eye, use of systemic steroids, whether it's to treat people who have pneumonias and have to take steroid packs a lot, or some people with autoimmune diseases who are on chronic steroids just to keep inflammation down in the body. Diabetes tends to cause increased rate of cataracts, or at an earlier age. And the main reason for that is as sugars get very high in the bloodstream, they actually get into the eye and soak into the lens and cause swelling, which can eventually cause changes to the lens of the eye. UV radiation, so your mother's telling you to make sure you wear your sunglasses outside and so on. Very important, because that does increase the rate of cataracts. And then smoking. Smoking causes everything, so why wouldn't it cause cataracts as well? So how do you know if you have cataracts? That can be tough, and a lot of people have no idea until I tell them. And the reason is what I see as far as in the eye, I might be able to tell there's some clouding, but with a simple change in glasses, it's not a big deal if we can still get you back to 20/20 and you can do your regular activities of daily living. So just because you have a cataract, or at least the start, doesn't mean you're ready for surgery. The times where we might know that you actually need surgery is if you come in complaining of your vision being blurry, we do everything we can with that huge machine that we stick in front of your face and still can't get you to be perfect vision. That might be a time to talk about cataracts, because that's likely the cause. If you tell me that I can't drive at night anymore, I see these glare and halos off these headlights and I can't tell where the lines are on the road, I just don't feel comfortable doing it. That's an effect on your activities of daily living, and so if that's important to you to be able to do so, then that's time for surgery. This isn't so much a reason, but a lot of times after cataract surgery, people tell me, I forgot what green looked like, or blue. I didn't realize trees were that green. And so that's just a nice perk of it. And then, as I said before, I can tell you when you have cataracts, but you're going to tell me when it's time to have them out. Cataract surgery is always an elective procedure, and so I don't do it until it is causing you enough stress or a big enough nuisance in your daily life to have it removed. So this is just a small example of how you can go from normal headlights to the glare with cataracts. And I do have a lot of people now that are complaining to me about those xenon blue headlights. That's not cataracts. Those are just an annoying, feature of those headlights, and I can't do anything about those. So how do we treat them? I kind of gave you a little brief description of the surgery itself. It's an outpatient surgery. You come in the morning, typically do it, and you go home that same day. So there's no inpatient stay about it. We usually perform it with you awake, and that's probably one of the most nerve-wracking parts of the surgery for my patients. And so I have to take time to describe to them the fact that we numb the eye very well. You typically receive some very light IV sedation. To be honest, a lot of my patients don't require any at all just because their eye is numb, and that's all that really needs. And the nice side of that is we don't have to put a tube down your throat. You get to go home usually about 20 minutes after the surgery done, compared to if we knocked you out, then you're usually there for about an hour just to make sure that the anesthesia wears off and you're safe to go home. During the surgery, we take a brand new lens. This is just one example of the different models that are out there, but we actually put that in place of where the cataract was. The nice part of that is I can order those custom made for your eye so that your distance vision is built into it. So about 70% of my patients don't require any glasses to see at distance 20/20 after surgery. The important thing to remember is that I can't give you back that flexibility of the natural lens of your eye you had when you were 20 years old, so you'll probably always need some small form of reading prescription after the surgery. So a lot of patients are just happy though to not have to wear any glasses from far away. If they get in their car and forgot their glasses, they don't have to go back inside to get them because they're going to be fine. Before I move on, any questions real quick about cataracts? I figured every section I'll just stop. Go ahead.
Does LASIK surgery impact your ability to later do cataract surgery on that same patient?
That's a great question. LASIK surgery doesn't impact us being able to do the surgery. What it does impact is it changes the contour of the front part of the eye. And so now whenever I do those measurements to pick that custom lens for you, we're still trying to figure out the exact equation, all the optics involved in order to give you the most accurate lens to give you that distance vision at perfection again. So as long as we can get your old measurements before you had the LASIK, which is hard to do because we didn't realize that was going to be so important down the road, we are usually 99 to 100% accurate. But sometimes it can be a little more tricky, but every year we're getting better and better at realizing how to do that. But in conclusion, no, it doesn't affect whether you can have cataract surgery. Go ahead.
Does your insurance figure into if you have your lens that you're putting in versus just a normal, regular type of lens?
Well, this is our normal typical. This is
Oh, okay.
standard, and so insurance covers us putting in this, what I call a standard lens. You may hear some advertisements and stuff for what we call premium lenses, and these are lenses that can have astigmatism built into them, and there's new ones out that are arguing or saying that they actually give you both distance and near. Insurance doesn't cover those because they don't feel that's absolutely necessary. So those are going to cost anywhere between $650 to $2,500 per eye for one of those special lenses. And we're still just watching and waiting and seeing. We're putting in the ones for astigmatism, but I'm still not putting in the ones that do the distance and near just because they haven't perfected them yet, and I'm not going to charge patients $2,500 for something that I'm not 100% sure of yet. All right, let's keep moving. The next topic is glaucoma. Glaucoma is a slowly progressive optic nerve damage caused by elevated eye pressure. That's a big sentence. We'll kind of just explain that more in detail as we go. There's a lot of types of glaucoma, probably 10 to 15 different types. The big one we're going to talk about today is the most common, which is open-angle glaucoma. So why does an eye have pressure in the first place? Where's it coming from? The eye is a large collection of living tissue that requires nutrients. Typically, other parts of the body get it through the bloodstream, but there's no blood vessels in the center part of the eye. So the eye actually produces a fluid with all those nutrients down here in this tissue called the ciliary body. And that fluid circulates through the front structures of the eye, giving the necessary nutrients to those tissues. And then once it does that, it has to get back out. And so it comes to this drainage system where it's supposed to drain out of the eye at the same rate that it's being made. So as long as that's happening, pressure stays the same in the eye. However, if fluid's being produced too quickly or it's not being drained quick enough, then the pressure can start to increase. And as it increases, that pressure gets transmitted into the back of the eye where it pushes on the optic nerve and can start to damage it. So this is typically with open-angle glaucoma a very slow process. Your pressure's not going sky high. It's just getting high enough that it's slowly causing damage to that nerve. So it can take decades before you even realize it. How do you know if you have glaucoma? Well, there's an estimated 3 million people in this country that have glaucoma. Only 50% of those estimated are actually diagnosed with glaucoma. So there's a lot of people going around out there who really have no idea. And to be honest with you, a large majority of them will probably never even know throughout their entire lifetime that they had it, just because it's so slow that usually something else catches up to you before it becomes a problem. In my experience, the majority of patients are incidentally diagnosed just whenever they come in for their routine eye visits. So they'll come in for something else, and during my exam I can see changes that are concerning to me, or they tell me something that kind of gives me a trigger to investigate a little more. Or some people just come in because their mother, their father, someone in their family had it, and so they figured they better get checked out as well. So how often should you be screening? If you have no risk factors, and I'll give you a big long list of what those are afterwards, you probably should get your eyes checked every 5 to 10 years. That's just for routine monitoring. If you do have risk factors, screening should be every 1 to 3 years between the ages of 40 to 54, every 1 to 2 between 55 and 64, and then after 65, your rate of risk for glaucoma or developing, it starts to increase a little more dramatically. So we recommend just annual screening from there on out. Whether you realize it or not, your eye doctor, whether it's an optometrist or an ophthalmologist, is screening you for glaucoma every time you come, whether it's that annoying puff of air that they do, or whenever they put that big green glowing thing right on the front surface of your eye. Those are all ways we're measuring pressure in your eye and basically screening you. Plus, during the dilated exam, we're looking at your optic nerves, and that's where I get the best indicator of whether there's anything going on. So here's that big list of risk factors. You'll notice right off the bat, age greater than 40. So there's one risk factor right off the bat of being concerned about glaucoma. Family history, probably one of our biggest indicators of what your risk is. Obviously, if you have high pressure in the eye. So high pressure is not always an indicator that you have glaucoma, because glaucoma means you have high pressure and damage. So if I see high pressures but no damage in your eyes, I can't call you a glaucoma patient just yet. African American race, prior history of eye trauma, diabetes, high blood pressure, and then those chronic steroid use again. Some people from steroids, they're just natural responders is what we call them, and that's for some reason or another, steroids can dramatically increase the pressure in your eyes if you've been on them for a long period of time. And that doesn't have to just be oral steroids, but eye drops as well. So my eye doctor told me my last visit I'm a glaucoma suspect. What does that mean? What's a suspect? Well, this means that something during that examination clued them in that there could be damage being caused by by high pressure. So, however, we probably would make you go through a series of tests and we still don't find that damage. So everything came up normal despite you having high pressure. So therefore, you're now a suspect. And what that tells us was we need to watch you a little more closely. When I declare someone a glaucoma suspect, basically what that means is over the next 3 years, I'm going to see you every 3 to 6 months, depending on how high risk I feel you are. And we'll do a series of tests. And over that course of time, at the end, we'll get together and we'll go over all of that information and determine whether you are a glaucoma patient, whether you're very high risk and we should continue monitoring, or if we have determined that, you know what, you were just born with those signs, such as a large optic nerve, compared to this normal one where you see this small opening, you have a little larger area of white. You could be just born that way, and now that we've ruled you out, we can just go back to regular eye exams. So a glaucoma suspect doesn't mean you have glaucoma and we need to treat you right away. It just means we need to watch a little closely and determine yes or no. So I make all my glaucoma and glaucoma suspect patients play the most boring game in the world, is what I call it. Some of you may have done this. Basically, your head gets stuck in this little fishbowl device, and they turn all the lights off, cover one eye, and they flash these lights at an extremely rapid pace, and you're expected to click a button every time you see it and stay focused straight ahead the whole time. It's kind of anxiety provoking for some patients. It's stressful for others. But basically, it gives me this readout. In a normal visual field, we'll have the black part being where you didn't see is your natural blind spot, and you should see everything else. But with glaucoma, you can see slowly over time, you start to have these other areas where you're not seeing anything. And scary enough, even this one here, you may not even realize that you're missing those parts of your vision because you have two eyes, and so one will overlap and make up for the other. But by the time you get to here, you probably are starting to notice. But that might be 25 years down the road. So if I can catch you here when you're not noticing any changes and start treating you, we can prevent you from ever reaching that point. And that's the whole goal of why we screen and we try to catch it early, because that's the most important thing for preserving your vision for as long as you want it. So here's kind of what the life of glaucoma is over, say, a 25-year span. You have your normal vision, and then over time you just start slowly losing these little corners, and it keeps going and going until you pretty much always keep your central vision, but you just slowly lose your peripheral over time. There's a lot of different treatments. The most common is eye drops. There's probably 25 different eye drops out on the market. But essentially, I'll use eye drops until I can't anymore, until I'm not getting any improvement in your pressure. At that point, you may need a laser done to your eyes, which can be done in the office. In the most extreme cases where I can't control the pressure, I'd send you to a specialist who can stick little drainage devices inside your eye, and that will actually keep your pressure under control. There's a lot of these different devices, but I just love this picture. They're not usually that prominent that you can actually see them just looking at people. They're usually a little better at hiding those, but that gives you a good idea of what these types of devices look like. Any questions about glaucoma? Good, I described it that well. Macular degeneration. So macular degeneration is an age-related disease. It's actually in the name, age-related macular degeneration. It typically affects people over the age of 60. It affects an estimated 15 million Americans. That's a big change from 50 years ago, and the reason why, well, we live a lot longer now than we used to, even just 50 years ago. So it's become more prevalent over time. Macular degeneration is when the cells in the back of our eye, in the retina, most specifically the macula, stop working. It's present in about 14% of all Americans over the age of 80, all Caucasians to be more specific. And interestingly enough, it affects less than 1% of Hispanic, African American, and Asian adults. So why exactly in the Caucasian race? They're still trying to figure that out, what the difference is between the different races and why it's more prevalent. You may have heard some people say, oh, I have dry macular degeneration, or I have wet macular degeneration. What's the difference? Well, the dry form is a very slow process, and that's where those cells in the back of the eye are just slowly stopping their function. And that's what affects 80 to 90% of all people with macular degeneration. There's no treatment for this. We can recommend certain vitamins that they've shown slow down progression, but there's no way to replace those cells or get them to function again. The wet form is what causes blindness in 80 to 90%. So dry form affects the majority of people, but wet form is what causes the most amount of damage. Wet is essentially a transition of dry. So what happens is, as the cells die, they tend to leave these little cracks in the surface of the retina, and those cracks are where little blood vessels that live behind can get through, and these are really fragile, and the risk is that they can break open and start bleeding. And so the wet is blood, or the fluid that gets released from these blood vessels, and those cause very rapid decrease in vision. So what happens then is, at least we have some treatment options for this, because what we need to do is to get those blood vessels to stop leaking and go away. So we have certain lasers, and now we have medications that we inject directly into the eye that are extremely effective at clearing this up and typically regaining at least some vision for these people. Since it is such a dramatic change, almost sometimes overnight, it can be quite an impact on your life. So it's pretty amazing the advances that we've developed as far as treating this just in the last decade alone. So I was told at my last visit that I have early macular degeneration. So what was the doctor seeing? How can he predict that? Well, there's these little spots that form. They're called drusen. They're very faint. And essentially what those are is places where the cells died, and now those cells were responsible for keeping that clean back there. So cells make byproducts, and so now there's nothing cleaning those byproducts up. So this is just basically a collection of waste material right in the center of the vision. So how does it progress? Well, you get these fine little drusen, and over time they start to coalesce and they get more prominent. And you can imagine that material, it doesn't transmit vision like regular cells. So those are areas where you usually get some dimming or loss of vision. And over time, you can transform. That's an awful picture. I don't know if you can see it. But you get one of those cracks, and now that's blood that's leaked in there. And so that's the transition to wet form. It doesn't happen in everybody, but if it does, that's essentially what wet is, and that's when people lose the majority of vision. So I like giving descriptions, or at least visual descriptions of what it would be like to have macular degeneration. This is a very severe interpretation, but you can see, opposed to glaucoma, where it took away your peripheral vision, this is a central vision problem. So when I tell someone they have early macular degeneration, how do we track it? How do I let my patient know, or how do I have my patient let me know if they think that things are getting worse? I have them go home with one of these grids, and I ask them to just put it up on their bathroom mirror, refrigerator, somewhere where they're going to pass by it once a day, once a week. And I just ask them, cover one eye and look at the black dot, make sure all those boxes are nice and straight, and then cover the other eye and do the same thing. Over time, if something's changing, they may see this weird distortion in the boxes. And I say, if you ever see that, you contact me immediately, because that's an indicator that they may be transforming from dry to wet form. And we have a treatment for that. So therefore, the quicker they get in, the quicker we can start treatment. How do we slow it down? We don't have a way of stopping it, but there are some things that have been shown to slow progression. Wearing sunglasses outside, that UV protection, those cells, why are they dying? Well, the theory is, the sun's radiation's hitting those and causing damage that's irreparable. So wearing sunglasses outside is a recommendation. Eat your green leafy vegetables. They have antioxidants in them. Those antioxidants help those cells repair themselves when they do get damaged. Taking a multivitamin. Just a once a day, I think, is a good way to start. My next slide, I'll talk about these vitamins that have certain nutrients or vitamins and minerals in them that have been studied, but they don't work for you unless you actually have been diagnosed with macular degeneration. So no reason to spend those extra dollars on something that isn't providing you an extra benefit. And once again, smoking causes everything. So stop smoking. AREDS vitamins. So these are based off of studies done that showed that certain vitamins and minerals have been proven to slow down macular degeneration more so than, just a regular multivitamin. They packed them all into these certain vitamins, and they've called them a formula and sell them to you for even more than, your once-a-day vitamins. They're still over the counter, but they're expensive. They don't decrease your risk of developing macular degeneration. All they do is they slow your progression once it's already there. So, once again, don't worry about taking those if just, you have a family history and you want to stop it. Just take a multivitamin. Save yourself some money. Any questions about macular degeneration? Yes?
My contact lenses say that they have UV.
Perfect.
As good as sunglasses or?
Yeah, absolutely. Yeah, anything that you have, contact lenses, if you have cataract surgery, some of the lenses we have built-in UV radiation into them, or protection. But for the majority of people who don't wear any glasses or contacts, sunglasses are definitely a recommendation. We're doing good. Let's keep moving here. Vitreous floaters. I probably get 5 to 10 patients a week emergently with, I have this weird floater in my eye all of a sudden. It can be a little concerning, and a lot of it's just describing to these patients, educating them on what's going on. So the vitreous, what is that? It's this jelly that fills the cavity behind the lens and in front of the retina. It's kind of like Jell-O when you're born. It's got that type of a consistency to it. As we have birthdays, what happens to that jelly is it starts to break down in the periphery and actually turn more into a liquid. Liquids are affected by gravity, so if it liquefies in the superior part, it actually will start to sink down through the jelly, and as it does, it peels off the retina where it was loosely attached, and as it does that, it clumps together and can become a floater in the center of your vision. Normally you're not going to be able to see them if you look in the mirror real close or anything, but that's something I would sleep whenever I look at you in my special lamp. But the symptoms of a vitreous detachment are flashes or flickers in the peripheral side. Sometimes people would say, I was sitting watching TV and I kept thinking there was this car going past my window because I'd see these flashes of light on the wall. And they realized that was this vitreous detachment causing these flickers out in the periphery. New floater, some people just wake up with, or all of a sudden they develop this big wispy thing that just moves in and out of their vision. They've never had that before. It is painless, and there's no vision loss. It may get in the way and seem a little blurry, but usually when we test you, your vision's perfectly normal. So why do you need to see me if it's a common thing or it's not causing any harm? Well, as it peels off, if you imagine taking wallpaper off a painted wall is the description I use. Sometimes as you take that wallpaper off, it can pull some of the paint off the wall with it. Same thing with the vitreous. Sometimes it can pull a little bit of the retina off with it, and that's a retinal hole. Not a huge deal, but if some of the fluid then gets behind it, it can turn it into a retinal detachment. That is a big deal. So if you come in and see me early, we can catch the hole, and I can actually use a laser and spot weld that shut so that no fluid gets behind and progresses to a retinal detachment. That's a big deal because a retinal detachment, I can't just laser. You have to have a very big surgery. Typically they put a bubble in your eye and you're face down for a week or two. No fun. It can cause bleeding as it peels. Sometimes it catches a blood vessel as it peels off. It can cause some bleeding and blurring in the eye. And we have to watch that for a period of time because the blood typically means that it probably tore the retina as well. But it also means that the blood can get into your drainage system and increase the pressure in your eye. So it has other risks that we need to watch. So I always say if you have a brand new floater or you're getting these flashes of light out in the periphery, if it's during the day, on the middle of the week, give me a call, we'll bring you in right away. If it's at night and all you're having is the flashes or floaters, I always hate to say this because you probably, if it's concerning you, go to the ER. But if it's just a floater, you can call us the very next morning, we'll get you in that same day. But if you get, let me see, these 3 symptoms, you go into the ER right away. Snow globe of floaters. So instead of just that one solitary floater in your vision, you're getting these raining down lots and lots of floaters. Go to the ER. Instead of just these occasional flickers off to the side, you get what looks like someone took a 4th of July sparkler, lit it, and stuck it in your eye. I want to know about that. Go to the ER right away. Or if you get a dark curtain, I think anyone would go to the ER if they started to just see black come over their vision. But that would definitely be a reason to go to the ER. Here's a kind of a representation of what a dark curtain over your vision would look like. So just a reiteration, see me as soon as possible. If you get any of those scary snow globe, 4th of July sparkler, or dark curtains, go to the emergency department. Any questions about floaters? Yes?
My mom has, she describes it as continual, like just multiple specks of dirt.
Mm-hmm.
And, you know, she's been seen by, I don't know, one of your associates out there. And what, are those floaters or?
Could be. Yeah, it's hard for me to tell. Sometimes if you're getting debris in just the tear film in the front part of the eye, that can give you those types of problems. If it's there all the time, it probably is floaters in the back of the eye. Yeah, it would be something that I'd at least have checked out, and if she, you know, isn't being sent to a retina specialist or anything, I'm sure it's just a benign finding. More of a nuisance to her than anything else.
Oh, yeah, because I mean, she's like rubbing the windows thinking there's dirt on the windows.
Yep,
It's, yeah.
that's a common complaint or description of floaters.
Yeah.
All right. Dry eye. I put this in here from last time I presented on these topics because this time of year, this is probably one of the most common complaints. Even if somebody's coming in just for a glasses check or something, this time of year, almost everybody that I see on a daily basis is telling me they're having some form of dry eye complaint. There's a really broad spectrum of severity and the complaints or causes or, I guess, symptoms of dry eye. They tend to have a seasonal variance. Winter, why is winter cause dry eye? We turn on our furnaces, and furnaces are dry. I mean, I'm sure your skin's cracked or anything if you're cleaning your hands after seeing patients all the time. But same thing, your eyes get dried out just because there's no humidity in the air. And it tends to affect women more than men by almost a 2-to-1 ratio. I don't have an exact reason why. I don't think anyone does. There's theories that women tend to have more autoimmune diseases than men. So that's one of the big risk factors for dry eye. So what are the causes? Autoimmune diseases, lupus, rheumatoid arthritis, Sjogren's syndrome. Some of those you may have heard of, some you may have not. But those affect tissues in the body, and they can also affect or attack the glands that produce your tears in your eye. So that's a reason why. Medications, there's a ton of medications that can cause dry eye. I can't even make a list of them, but if you look at pretty much any packet insert on a medication, dry eye is probably listed, especially for, you know, diuretics, sinus medications like your pseudoephedrine, Sudafed. Hey, smoking, why not? I mean, obviously, if you're smoking, the smoke's getting in your eyes, it can cause dry eye. Eye makeup, that's my arch nemesis for dry eye. Buildup of natural bacteria on the eyelids, CPAP machines. If you imagine that those CPAPs are blowing high rates of air into your respiratory system, and if you have any small leakage here, it's just sandblasting your eyes all through the night. Facial nerve palsies, Bell's palsy, causing the lid not be able to close the whole way. These are just some of the ones off the top of my head that I listed for you. And just so you can kind of visualize, imagine if you have an old machine and you're not getting a proper sill. That air is coming out of there pretty darn quick. If you've ever put on a CPAP, I liken it to sticking your face out of your car window at 55 miles per hour. It takes a while to get used to those things, but that air, I mean, imagine that hitting your eyes in the middle of the night. Women come in complaining about dry eye, and I see this beautiful eyeliner that they put on that morning. There's glands, there's oil glands on the ends of your eyelids here, and those are responsible for providing a certain part of your tear film. And that's essentially like taking a cement roller and just capping them over. I mean, they can't function when they're buried under this layer of makeup. So if you're having dry eye, I implore you, just take a hot washcloth at the end of the night, get that stuff off of there first thing, and let them breathe again and just let them work. They will over time. If you keep them covered long enough, they'll start to scar down, and it can be a real struggle to get them functioning again. So just be careful with that stuff. So what are the symptoms of dry eye? Redness, itchy, watery. Why watery? If I have dry eyes, why am I tearing all the time? Well, what happens, say you're outside in the wind, and the wind is blowing in your face and dries out the front part of your eye. It sends an emergency signal to your lacrimal glands, and it's essentially like those cartoons where you see the firemen throwing pails of water on the side of a burning barn. It's just dumping large amounts of tears onto the eye to just get them coated again so that they're not sending that SOS signal. And you can't drain them as quick, so they start running down the sides of your face. So that's how dry eye causes watering. You can get that feeling like there's sand in your eyes. Glare issues, blurred vision, and tired eyes. End of the day, you say, I sit down, I want to watch TV or something, but my eyes, I just fall asleep. Imagine if that's your tear film. And so these specks, that's where you have dry surface. If that's right in front of your vision, that's going to blur you up. That's how it causes blurred vision. And they become damaged, and once you become dry, the cornea becomes damaged, and they're not crystal clear anymore. How do we treat it? I have a ton of different options. I usually start out very conservative. It might be as simple as stopping certain medications, like a sinus medication. But a lot of times it involves correcting a tear film deficiency. So the tear film, there's 3 layers to it. The most important is the oily and the water layer. So the oil layer sits on top of your water, and it prevents them from drying out. So if I can keep that intact, that tends to decrease your symptoms. And then for people who have autoimmune diseases, other issues, they may not be producing enough of their watery tears as possible. And I'm sorry, I'm speeding up just to make sure everyone gets out of here in time. So how do I treat the oily layer if that's your problem? And I can determine whenever I evaluate you whether you're having an oily deficiency or a watery deficiency. So if I appreciate that you're having an oil issue, I might tell you to start making sure you remove your makeup at night, because that's what that's affecting. And the way you do that is you take a real hot washcloth, just put it on your eyes and give a gentle massage. Artificial tears, 4 to 6 times a day. Artificial tears have all components of the tear film built into them. So it will supplement your watery layer, your oily layer, whatever you're missing. You can use an artificial tear ointment at bedtime. That just provides extra lubrication through the night and allows them to catch up and get rehydrated so that at the beginning of the day you're not starting out at a disadvantage already. And some people who have rosacea, that can actually affect the glands in your eyelids that produce the oil. And so sometimes I can give you an antibiotic that helps decrease the amount of bacteria on your eyelids and actually helps thin out the oil so that they flow better. And that's where an oral antibiotic can provide some help. If you have a watery layer deficiency, it's probably because you have some form of an autoimmune disease or your lacrimal gland is just not working the way it should. So I start out with usually the same plan: hot compresses, artificial tears, artificial tear gel, stopping the medications. But some people are just so severe that those don't work for them. So sometimes I'll have them wear protective eyewear. They make these sunglasses or glasses that have this foam that kind of prevents wind and so on from getting up into your eyes and drying you out. I can put in punctal plugs. We'll get to those. I might test you for Sjogren's and lupus and other autoimmune diseases, because if you treat the systemic disease, a lot of times that helps your eye complaints as well. And then everyone's probably seen the commercials for Restasis. They're doing a great job advertising that like crazy. They spend a ton of money. And for some people with Bell's palsy or a facial nerve paralysis, sometimes we have to do surgery and either close the eyelids a little bit more, or even sometimes I put a gold weight in the eyelid just to give it a little extra weight so it'll close the whole way whenever they want to blink. Plugs in what? Where are you putting plugs? Punctal plugs. So a puncta is the opening on your eyelids that drain the tears. So for people who aren't producing enough tears, sometimes I don't want you to be draining them away. I want them to stay on the surface of your eye for as long as possible. So right in my office, I can stick these little plugs into those openings. It's painless. I numb you up and you don't feel a thing, just with eye drops. No injections, nothing. You don't feel anything. If you do, you can kick me under the slit lamp. But sometimes plugging these up just keeps the tears on the surface of your eye longer. And for the people that I choose, I'm pretty selective in who needs these. It provides a pretty significant benefit. Restasis. A lot of people come into me and they say, I have dry eye, I want Restasis. Because they've seen the commercials and they've been told that it will make their eyes better. There are a whole host of causes, so I might not recommend it to you the first, second, third time you come into me with this complaint. A, because it's very expensive. Last time I checked, it's about $550 to $600 a month for this treatment. It doesn't treat every form of dry eye. It has very specific people who it helps. But it's just not for everyone. And so if you go in with the mindset that you're going to get that and you don't, there's a reason. You know, an ophthalmologist doesn't, it's not they have something against you, a grudge, and they're keeping you from the miracle medication. It was originally developed to prevent transplant organ failure because it's such a good way of protecting or keeping the immune system from really acting out. And they also found that when you stick this in your eye, it decreases the inflammation. So it's really built for the people with autoimmune diseases, Sjogren's, lupus, who are having an autoimmune cause for their dry eye. And I apologize, I sped up for that last bit, but any questions about dry eye? Well, thank you so much for spending this morning with me. I hope you got something out of that. And I think we're going to do a collection and do a little drawing, right?
Hey, Dr. Strittmatter, I got a question
Yes,
for you.
yes, please.
So, it's personal in nature, and you can charge me if you want.
Sure.
So I struggle with red eyes for computer, long usage, and whatever, dry eyes. And so every once in a while I use Visine. Is that a good thing or a bad thing?
So that's a really good question. Every patient I see with red eyes, dry eyes, one of the first things I do tell them is, please do not use Visine.
I would have thought.
Yeah. So Visine has a certain little preservative in it or a medication that constricts the blood vessels so it makes your eyes nice and pearly white. But what happens is after it wears off in about 2 to 4 hours, it actually causes rebound vasodilation. So the blood vessels get even bigger and more red after it wears off. So that's a really nice cycle for Visine because now you get rebound redness. What are you going to do? You're going to put another drop in. And so you get into this routine of using it pretty regularly, buying some more. And it keeps working, but it's actually, especially with that way that it's constricting the blood vessels, it's actually leading to dry eye even more over time. So a good non-preservative artificial tear is usually your best way to go. And just taking a break, going, having a washcloth. I can't tell you enough how important I think it is just to really get those oil glands functioning on the front surface of the eye. Because when you're reading or looking at the computer, you're only blinking 5 to 10 times a minute. Whereas when we're sitting here talking, we're blinking 30 to 40 times a minute. So your eyes are exposed that much more when you're doing those activities. So having your oil glands working by doing those hot washcloths just helps keep them protected.
Thank you.
Mm-hmm. Go ahead.
So you were talking about eyeliner being like a form of cement layer.
Yeah, I knew I was going to get some heat for that.
Oh no, my question is, what about the people that have their makeup tattooed on?
Yeah, that's a good question. It doesn't really cause as much of an issue. Those glands do tend to function through there. Yeah, that doesn't seem to be that bad of an issue. It's the makeups that get really caked on there that are on the surface covering the glands that cause an issue. Go ahead.
Do you have a relationship with migraines and floaters? People with migraines that starts out with floaters?
Well, so migraines and floaters. Usually migraines, the floaters that you get, or we call them auras, are usually temporary. And so a migraine shouldn't cause floaters that persist in your vision even once the symptoms of the migraine subside. typically whenever you get those spots, or we call them some people say they're these dazzling lights that they get whenever they have migraines, those tend to dissipate over a half an hour, and then you don't see them again. Whereas a floater, when that happens, those will probably be in your vision forever. They do not subside. Your brain gets smart at phasing them out, so you only appreciate them in certain environments. But that's the big difference, is migraines, floaters are temporary and subside. Anything else? Katie? Oh, I'm sorry, do you have one more?
I was just going to, with retinopathy, are you able to still have LASIK surgery or no? Is that something you should do?
Retinopathy from diabetes and so on.
Yeah.
So that is up to the surgeon. Typically, it depends on how severe the retinopathy is. Diabetes in its, for a long time in itself was a contraindication to having LASIK done. Just because diabetes delays healing. And so whenever you have LASIK surgery, healing is really important that it be quite quick, so that they make a flap on the front part of your eye, and if that doesn't heal close, it can shift, move, and then it distorts your vision and you end up worse off than what you were. So I don't do LASIK, but that would be up to the refractive surgeon. Good, yes, Katie.
Is it true that eating carrots is good for your eyesight?
It sure is, yeah. Not only does the beta carotene in carrots help with letting you work or see better at nighttime, it improves your overall night perception, but it also has antioxidant activities. And beta carotene, which is in carrots, is one of the vitamins found in the ARIDS formula vitamins for macular degeneration. So it's just a natural way of getting this vitamin that's proven to slow macular degeneration. Any fruit and vegetable helps your eyes. I'll just put it that way. Anything with an antioxidant in it is good, because the retina is one place where antioxidants are used at a very high level.
See? We're not pushing those things just for the heck of it.
Right. All right. Well, thank you so much.
Excellent, thank you. I would just like to call attention to this slide and your comments, Doctor, about people not being able to find us necessarily.
Yeah.
I'd let you all know that we have approved signage, and we'll be adding it very shortly to the other side of this canopy. It'll be on the building on the other side. It'll say eye care. So it will be very difficult to miss, although these are eye care patients, so we'll see.
It's true.
And I also would like to mention that today we're piloting something new at the noon session. We have a Noon Express. You may have seen this in some of the marketing and messaging, and we'll see how it goes. It's something that we've heard in these comment cards. An hour is too long for some people, especially in the clinical setting. We could sneak down for half an hour, so we're trying this. Dr. Strittmatter will be back for a 30-minute version of this. So if you could please spread the word to those of the friends and associates that you work with who you know would like to make it but can't always get the full hour in. If it's successful, we'll continue doing it. If it's not, we'll try something else. So if you could share the word on that, I would appreciate it. Now we've got it.
Oh, I get to do the drawing
Yes,
here.
drum
All
roll.
right. I always get nervous about the names. And of course, I picked one that I'm going to be nervous about. Leanne? Is it Shorka? Hey!
All right. Thank you very much for being here.